morning, this afternoon, we have the distinct pleasure of welcoming our very own Dr. Tom Wood, who's the Director of International Health Programs here at Samaritans Purse. Let me just say that Dr. Wood, he's got nearly 50 years of field experience as an epidemiologist, and much of that time has been dedicated to the well-being of children around the world. Dr. Wood is busy implementing a community-based initiative in which we actually train up village healthcare workers within their own villages to provide primary health care to their village. And let me say that program is proven to save an enormous number of lives. So we're delighted to have Dr. Wood speak to us this morning. So Dr. Wood, I'll turn it over to you.
Hello, and those of you who happened to attend the prescription for renewal last week are going to be a little familiar with my topic here. But the thing that I wanted to say up front is, this topic is, although it relates distantly to epidemiology, it relates primarily to children and the state of health care for children around the world. And, the fact is that, the number of children that are out there, the number of children that are affected by simple infectious diseases, and the title of the talk is, Children in the Developing World, Simple Diseases That Kill. And today we're going to be talking about just about three of those, and because it's the three where we can most easily have an impact, and it's the three where an impact would actually, if we could reach every one of the children that suffer from any of those three illnesses, we would reduce the children under 5 death rate around the world by 2,800,000 just in 1 year. So it's a formidable challenge. You will see why as we go through the paper today, through this talk today, but it's one that I think is very well worth taking it on, and I do believe it's one that Jesus would have us to take on. And I'm not the only person that feels that way. There are other champions of this field out there. The program is called Community-Based Primary Health Care. Is what that is the generic title of it. Here at Samaritans First, we call it the Village Samaritan Program, and the thing that we bring to it, into this fight in the field, is we bring the spiritual aspect into it. And if we take a look at how Jesus felt about children, I think the Bible's pretty replete with what he had to say about the children. But the one that I wanted to bring to your attention today, just to read a little scripture to you, is in Matthew 18 and 1 through 5. And it says at that time, the disciples came to Jesus and said, "Who is greatest in the kingdom of heaven?" Then he called a child to him and had him stand among them. And he said, "I assure you," he said, "unless you are converted and become like children, you will never enter the kingdom of heaven. Therefore, whoever humbles himself like this child, that one is the greatest in the kingdom of heaven. And whoever welcomes one child like this in my name welcomes me." There was another place, and it's recorded in all three of the Gospels, where Jesus was in a crowd of people crowding around to see him, and his disciples at the time decided that the children were somewhat of a nuisance, and started blocking them coming to Jesus, and he very quickly warned them not to do that. He said, "Let the little children come to me, for such is the kingdom of heaven." And so my passion for children comes from one, as I get older, there's two things that become more beautiful to me every day, and that is the face of a child, and then beyond the face of a child is the face of older folks, because you can see God very clearly in either of those. But we're going to focus today on the children, and The title, as I said, is Children in the Developing World, Simple Diseases That Kill. The beautiful eyes of this little Honduran girl are just a part of what lures you into, seeing what we can do to reduce their suffering. This picture that I've got here, the slide that I've put up now, is to bring some of the statistics to your mind. If this were in PowerPoint, which it's not because we're on Blackboard Collaborate, but those 8 pictures of the children that are down the edge of that slide, I have it set up so that one of those disappears every 4 seconds until all 8 are gone. The point of that is that if we read down, it says, in today's world, in spite of advances in medicine, and I'm saying that in spite of advances in medicine because we can save the life of every one of these children. We have digital technology available through e-medicine. We've got mobile technology available through the mobile phone so that we can get word out. We have new vaccines that are coming on the market. We've got new pharmacologic discoveries, and we've got modern medical practice. So, the things that are available are, in spite of all of those, we have a child that dies every 4 seconds, to the child under 5 years old, before they can celebrate their 5th birthday. Every minute, a woman dies of perinatal complications in the world. Many of those deaths would be preventable. And in 2008 in Africa alone, there were 880,000 babies were stillborn. 1,243,000 children died before reaching 1 month of age. And so that's the figures I want to focus on. And if you look down those pictures on the edge, these are pictures of 8 beautiful children from various places around the world: Honduras, Bolivia, Africa, Southern Sudan, and Mozambique. And so these are children all over the world. Those of us who, and I have sitting in the room here some very experienced people, and then on the line, same with you, Chuck, out there. Chuck, you've already heard this talk, but you're going to hear it again, Chuck, is that everything that I say does not in any way negate the work that has been done by medical missionaries around this world. Dick Bramford's sitting here, and I know the work that he has done. We've had the opportunity or the pleasure of listening to him talk to us about that. So medical missionaries and people working in medical missions hospitals work around the world saving lives, and they've had a major impact. And, you add to that the fact that in many areas of the world, the one I put down here, and this is an average, there's less than 1 physician for every 3,000 people. And there are places in Africa where that's 1 to 10,000 or 1 to 20,000. Wow. So, that points out a need, which I will address a little bit later, and one of the possible solutions to that shortcoming.
Tom, how many countries in Africa have even that ratio?
That's an average, of what I said. So it's like I say, it's 1 to 10,000, 1 to 20,000 is not unusual in many countries in Africa. Well, I want to bring this in. If you were interested in getting data on world statistics about, what's going in the arena of health, you can go to, it's called indexmundi.com, and that's where this data came from, and these graphs came off of that site. But the thing I want to show you by this illustrates very well. This is the gold or the brown line on this represents the statistics of under 5 child deaths per 1,000 live births worldwide. And it shows you that starting at about the late 60s, early 70s, that's when the data started being kept internationally, that the rate was up in the neighborhood of about 180 plus children out of the per 1,000 live births that died before they reached their 5th birthday. But the impact of medical outreach around the world, the fact that starting about that time the non-government organizations began to grow in number and to begin, and so we had things like, sanitation and hygiene training that were going on, and we were making forays out into many areas of the world, particularly in Africa and other areas as well. And it had an impact. I just saw that my daughter-in-law has just she's laughing up there. Yeah. These are the statistics here for sub-Saharan Africa, and what we need to look at is over on the left-hand side of that, and I apologize for the small size of this, but to get that larger graph in, we had to reduce the size. If you look over on the left-hand side of that, you'll see that the scale has changed from the previous slide. I'm going to splash back so you can see that. The scale changes. The top figure on that one there, or near the top, is in the 160s, and the top figure on this one for Africa is in the 200s. So starting, in the dates on those figures, the death rate was, there were at least, like 25% of the kids in that time died before they reached their 5th birthday. The death rate was very large. You can see that we've had an impact on that, both by the interest and growing expansion of efforts by the host countries themselves or the countries themselves, but by the intervention of medical missionaries and of NGOs. We've been able to bring that down. You can see there was a period there in the in the late 80s when that leveled off, and that was a period of time when there were many of the civil wars that were going on in Africa, so that there was a disruption of service delivery to them. But then it started down again, as we approached the 90s, and then that downward trend has continued. If we look at the sub-Asian continent, or South Asia as it's called today, we can see the same impact. The scale on the left, again, if you've noticed, has changed, but the bottom line, the blue line down there, is the United States, and I put that in purely for comparison. And the blue line over towards the right-hand side of that graph gets down to our U5, what they call CMR, crude mortality rate, and that's the number of deaths per 1,000 live births in the United States, is 8. And that is 3 or 4 times the rate that it is in several of the Scandinavian countries. So we have a ways to go here, but we're still far, far below, the figures for South Asia and for Africa. Going back and just putting some statistics into this, that if we look at the world, approximately 14% of the children born in 1970 would not live to see their 5th birthday. By 2011, that percentage had been reduced to 5%, so that it had been more. The rate of decrease was more than double. If we go to sub-Saharan Africa in 70, it was, like I said earlier, 1 in 4 children would die before their 5th birthday. That's 25% of the kids that were born in 1970 would not live to see their 5th birthday. And go to 2011, we've reduced that to 1 in 10. So still, but that's 10% of the kids that are born in Africa today won't live to see their 5th birthday. If we look worldwide at the crude mortality rate in children from 2 diseases, and this is from pneumonia and from diarrhea, we can see that the figures of how those deaths are distributed worldwide, and you can see the greater majority of those are in sub-Saharan Africa. The figure that's cited here is 1,078,000. South Asia was 851,000, and the rest of the world was 268,000. So, those 2 areas are the areas where we, have a large focus here in Samaritan's Purse, and where the need is the greatest. That 20% there that's left, that little bit up at the top there, includes Latin America, which is also very high. I can't see your pointer. Okay. Yeah, and if we take a look at this figures here, we can go over into the, and the things that we're going to be focusing on. I don't see if I'm grabbing that.
Did you click it?
Okay. We can look at pneumonia, which is responsible for 18% of the deaths in children. On this particular graph, I will tell you that depending on which graph you're looking at and the data from which data set you're looking at, this figure will vary from 14 to 18%. But on this particular figure that was published by the Child Survival Initiative, it was 18%. We look down here at diarrheal disease, and you can see that the combined here between the 11%, that it has is combined figure. Most of the data that you will see, that you will see out there says 14% for diarrheal disease. And then the third biggest one, the one that we'll look at today, is over here, and it's malaria. Malaria is a scourge of South Asia and of Africa, and it results in about 7 to 8% of the crude mortality rate that we see today. There's a very large distribution, as you can see in the rest of the chart there. But this one breaks it down into, and so what we can do with the approach that I'm going to be talking about today is to affect that percentage that. Then overlying that, malnutrition contributes to a 30% additive to those diseases. So there's a 30% higher likelihood of children who are malnourished and getting one of those diseases dying than if they were well nourished. So malnourishment is a big area that we here at Samaritans Purse focus on, and with good reason. I put it out here in just straight figure, and I underline with that beautiful little child there, just to remind us of what we're talking about. And this one shows you that this chart says that the pneumonia was 18%, the diarrhea 14%, and malaria 8%. And those are the ones we focus on and are going to focus on in our talk today. When we're talking about pneumonia, and that's the one we'll look at first, recent developments in vaccines with the advent of molecular biology and the ability to separate out parts of an antigenic component and attach that to a bacterium that we can grow in large numbers in the laboratory and then use that, for making vaccines. I've made a couple of vaccines now available to us, two of them which we'll talk about here, and one is the pneumococcal conjugate vaccine, and the other one is a vaccine against Haemophilus influenza type B. And both of those are very large contributors to the number of child deaths internationally, particularly in the countries where we're focusing. Immunization has a large impact when we look at the ways of reducing and preventing pneumonia, and we all know that not just the Haemophilus influenza and the pneumococcus lead to pneumonia, but so do measles, whooping cough, and other causes. A big thing that has happened for us in that arena is that just besides the advent of those vaccines, is in the year 2000, January 2000, there was a partnership formed of private and government and NGOs, and that partnership is called the Global Alliance for Vaccines and Immunizations. That has been a very powerful partnership and has taken vaccines and vaccinations out in quantity and in mass to the people. For example, there was a recent outbreak of polio in the Horn of Africa and wild polio virus, and Gavi, as it's called for short, was able to go in, and within a week we're able to immunize 50,000 children in Ethiopia, against wild polio virus. So Gavi is very, very effective, combined with UNICEF, UNICEF purchases and makes the vaccines available. And then Gabby now has the partnership in place to get those vaccines delivered. We just saw them go in and into the northern part of South Sudan and do the same thing. There were 50,000 vaccinations against that polio virus that took place in northern South Sudan just in the past couple of weeks.
Any idea the cost of those vaccines?
Have no idea. The fact is that when we're out there doing it, UNICEF provides them for free. We tell them we need measles vaccine, they will bring it. Where they're getting it from us. We purchased it for UNICEF, but it's being made available and it is having an impact, a very large impact. Another thing that's happened is the rediscovery, I would say, of the importance of zinc as a supplementation in both in the treatment of, and you'll see, pneumonia and diarrhea. And you can see the zinc supplementation in the populations that we were dealing with in this particular study reduced the incidence of pneumonia by 13% and the prevalence by 41%. That is a very large impact. The investigators in this study also reported that the use of zinc reduced the incidence of pneumonia diagnosed by a specific clinical criteria, and that is, going into to a fairly advanced clinic and diagnosing pneumonia through rails and X-rays and that sort of thing by 21%. But the interesting thing is, and this slide has a mistake in it. It says, but had measurable effect. It had no measurable effect on lowering the, lowering the pneumonia in cases that were diagnosed by either rapid breathing or by nasal flaring. So go ahead.
I don't want to misspeak. I know the benefit of zinc in treatment of diarrhea is, I'm fairly sure, unequivocal. If I'm not mistaken, when Dr. Phil Fisher spoke recently or several months ago about pneumonia and zinc, I thought he questioned its effectiveness based on some new studies, but I may be wrong. I thought he did.
This is the latest that I've been able to find, and
okay.
They say that it is effective. Now,
okay.
I would like to go back and review that.
Well, that's what I thought when I spoke at the heart. That's the data that I found. Definitely still advocated for use of zinc in treatment of pneumonia.
Right. Well, until we proved otherwise, I think that we'll go with this data.
Well, it's certainly innocuous. I mean, I don't think it's going to cause any harm.
It's not going to cause any harm. And besides that, not only in the treatment of diarrhea, we'll see in a minute, but in the treatment of diarrhea, not only does it help the person who is suffering from diarrhea get better sooner, it protects them from reoccurrence for several weeks afterwards.
Mm-hmm.
Hygiene, we all know, I just put that in there just to remind us of the impact of hand washing and of proper sanitation, and particularly with pneumonia, it's mainly the hand washing to prevent spread, but the impact there, I don't have any figures on it other than the fact that we know that it's important, and so we should not negate its, the continued treatment of, the continued teaching of hygiene. For treatment, the World Health Organization has come out and made a very bold statement, that is, pneumonia should be treated with antibiotics. Most cases of pneumonia require oral antibiotics, which are often prescribed at a health center. And then they went on to say that these cases can also be diagnosed and treated with inexpensive oral antibiotics at the community level by trained community health workers. Hospitalization is recommended only for severe pneumonia cases now, and for all cases of pneumonia, of course, in infants that are younger than 2 months of age. But they're finding this to be very effective to put these antibiotics in the hands of trained community health workers, and then to go through the diagnosis of rapid breath or nasal flaring or chest indrawing, and use that as a criteria, and then to give antibiotics, and it's saving a lot of children's lives. Go ahead.
Definition of trained community health workers.
Yeah, trained community health workers, will tell you it's very broad. We put them through a training program for the village Samaritan of 6 weeks. in which we give them fairly in-depth, we show them what the lungs are, how the lungs function. Then we give them training on how to count breaths and training. If they can't count, because they don't have that ability, you can have them move beads. But training, if you go to WHO's training for the community health workers, they do their entire training on these 3 diseases in 5 days. So training is very loosely
coming in can read and write,
and the one with WHO's,
yeah.
They would prefer that they are. I don't know whether they can train the illiterate or not. Our program is set up so they can. Okay. I want to focus next on diarrheal disease and the things that are out there and the things that can be done about it. For all of us that are in the health professions, we don't need to go through an extensive list of the agents that can cause diarrhea, but I put this up just to tell you what the main ones are that are out there. Of course, we've got Shigella listed here, but Shigella causes a dysentery, which is blood in the stool, defined as blood in the stool, and so, but it's here because it's, that is a form of diarrhea, but it's dysentery. Okay, and then the other big ones that are out there in the field are the enterotoxigenic E. coli, rotaviruses, and Giardia. It was a surprise for me to see it that high, on the scale, on the international scale. But then, this whole range of them here and combinations thereof are what contribute to diarrhea in the field. We have recently developed, and I put that down here, a vaccine against rotavirus. And rotavirus is the leading cause of severe gastroenteritis in children worldwide. And with the availability of this vaccination, and now Gabby having the vaccination teams already in place for immunizing the children, we can expect that immunization will take place fairly rapidly, so that we'll see a reduction in the number of cases of rotavirus-induced diarrheas. I won't go into reading that. It just goes in just a little reiteration of what I just said.
Go ahead. Out of curiosity, with that rotavirus vaccine, can you speak into how widely distributed it is?
Currently not, but it is in the process of being distributed very widely.
Because I think that would have theoretically have a tremendous impact on mortality associated with acute diarrhea.
8% reduction is the result of it. Yeah, exactly. So
8% reduction
in mortality associated,
rotavirus.
Yeah, rotavirus. So, I've got a picture here on the right-hand side. Janet should have been sitting here in the room. It's a latrine that was built around the camp in Doro. Doro recently had an outbreak of hepatitis E. And when they did, they went in and refurbished all of these latrines around the edge of it, and you can see a nice latrine and a hand wash station there. And there were numerous latrines, but I wish I could, if I could blow that picture up, I would take you down to the doorway and show you something of the things that the epidemiologist looks at, and that is that there is no path into that latrine. In fact, in spite of the fact that the tents for these refugees are that close by, there is no path worn from those tents out to that latrine, not being used. When we, Lance and I went over and we interviewed 3 young ladies at a feeding center, and, the first young lady came up and she was giving us all the answers that one would expect. We're the NGO, and she knows what we expect here, so she's telling us. And meanwhile, the second young lady, who was kind of a stubborn young lady, you could tell just from the way she was heckling her, the one we were interviewing. Then she got up, to be interviewed by us, and she quickly told us that she got her water from the stream. She did not like water from the hand pumps. That the defecation was open defecation because she didn't like going in stinky latrines, And and then she told the other woman, "And you do that too, don't you?" And the other woman finally said, "Yes, she did." So, the fact is that we can do all these things with the latrines, but we've got to get them somehow so that, to the point that they'll use them. That's a side point into that, but they're there. It is a good technique. We need to make people, to get them behavior change in order to get them to use it. But the thing that is and has become available is oral rehydration salt solution, and I have experience with that dates all the way back to 1963. That is, I was in Taiwan and worked at the Naval Medical Research Unit number 2 in Taiwan in 1963. And 1963 is when El Toro cholera first made its appearance in Asia, and had first made its foray off of the mainland of Asia out into the Philippines. And so that every year in the Philippines we would have an outbreak of El Toro cholera. All of that to get to the point that my commanding officer at that time, I was Navy, was a man by the name of Bob Phillips. And Bob Phillips, if you'll go back and research the literature on the development of ORS, was the first group, it was NAMRU 2, where we developed the basis for ORS. And that basis did not include glucose. That was added later by an Indian group and found to be very critical to the effective use of ORS. But ORS has been around then in its development since 1963, but it's come into widespread use now. And the thing is, lately, that slide tells you that it's just a replacing of the essential salts that are necessary for moving water from the gut into the bloodstream, and then from the bloodstream into the cells, and replacing that, in the event of diarrhea, and so that the fluid loss that the child, in particular, that are susceptible to it, the fluid loss is replaced by fluid intake, and the fluid is not just washed through. It actually is picked up and taken into the body. So ORS promotes that. Children under 5 are very reluctant. If I ask at the PR, the prescription for renewal, how many people in the audience had ORS, and I got about 5 or 6 people. And Janet's just sitting here. Though, for those of you who don't have television looking into the room here, Janet's making a face. It's very difficult it's a very difficult solution to drink. It's like drinking sweat, and and not only sweat, but concentrated sweat. And so to get a child to take that, even if the child is sick, it's very difficult. So what they've done is they've said, okay, what is it about that makes it so unpalatable? And it was the sodium concentration. And so they've reduced the sodium concentration in one called low osmolar ORS. It's not only as effective, it's more effective than the original formulation for it. And it's much more palatable to children. So for those of you who are out working on treating diarrhea in the field, definitely insist on having the low osmolar ORS. And it probably in the very near future will become the only one that's available on the market.
Now, what happened to the old 3 fingers and 2 fingers?
Still there, except not recommended by WHO anymore because of what you're putting in when you take the fingers to make the solution.
So what's been in the cup that they...
How clean their hands are.
Yeah, and homemade ORS works. It does not work as well, and so it's as inexpensive as this program because it doesn't have the molar concentrations. It's just they develop. This comes close. Okay, and it doesn't have the potassium salts in it other than what you get from what you put into it.
I'll ask you the same question before. What's it cost for ORS?
ORS is probably now I used to say 10 cents a package, but it's less than a quarter a package.
And how much for the 2 fingers and the 3 fingers?
I don't know. Okay, Dick, how much? Pennies, if that much, yeah.
Which means if it's pennies, it may be 800 times more expensive to buy the package.
Yeah.
And what you put in there with the water is going to...
And I agree with you. And there are places where I've been in the world where I say, a dime a package or a quarter a package. For us, that really doesn't make anything. But there are people out there that if they have to spend that to buy it, they just simply don't have it.
Right.
Yeah. zinc supplementation has proved very beneficial in this area, and then, I'm going to read this to you. It says, according to the WHO, supplementary zinc benefits children with diarrhea because it is vital to micronutrient. It is a vital micronutrient essential for protein synthesis, cell growth, and differentiation, immune function, and intestinal transport of water and electrolytes. Zinc is also important for normal growth and development of children both with and without diarrhea, and zinc deficiency is associated with increased risk of gastrointestinal infections, adverse effects on the structure and function of the gastrointestinal tract, and impaired immune function. So, it is very beneficial, and any of our recommendations that go forward to the field through any program that we have recommend the use of zinc. I put this chart in but just to kind of show you that there's an overlap between prevention and treatment areas, but to re-emphasize that apart from vaccination, treatment is easy. And the use of it is, the decision to use treatment. WHO says in all cases of pneumonia defined by age-specific breathing rates and, nasal flaring and chest indrawing, diarrhea by more than 3 stools a day, so that, the use of antibiotics and the treatment of those is not recommended for diarrhea, but recommended for pneumonia, and then the use of ORS for diarrhea, because most of the diarrheas with ORS will self-resolve. Then the last one, malaria. I put in here something that a pet peeve of mine, and it's not a pet peeve of mine, it was a worldwide travesty. And that was that in the 60s marked the beginning of the age of pseudoscience, and literally drawing history-changing conclusions based on hysterical reactions, to limited information. And we've seen a number of outcomes of that throughout our culture. But this one had the biggest impact of all, and that was in 1960. In the 60s, a book was published called Silent Spring by an author named Rachel Carson. And I don't want you to listen to my words, but just look at the bottom there in the gray area. And it says the false crisis of Rachel Carson, which argues that the number of Carson's major arguments rested on what can only be described as deliberate ignorance. Much of what was presented as certainty, then was slanted, and today we know was simply wrong. What happened was DDT, and we were coming very close to the eradication of malaria in the 50s. We were probably a year to a year and a half away from the eradication of malaria with the use of DDT and spraying, internal spraying, residual spraying on the walls of the huts and houses. And this book was published. DDT was withdrawn from the world market, and malaria, which had been very severely curtailed, sprang back to life and has since killed literally thousands of children. Millions, yeah. Okay, yeah. Of children. So, all that said, DDT is coming back into use, but it's coming back in slowly, and the reason slowly is one is manufacturing sources that are few and far between, especially in today's litigious society that we live in. And the other is that countries are very slow to redo their importation laws and stuff, so that getting DDT into many of the countries where it's vitally necessary or very necessary is a slow process. It's happening, but it's happening slowly. Okay.
There's still many environmentalists who believe this garbage that this woman wrote.
Yes, there are. Yeah, so we got a process of trying to convince them also. Okay. The next thing that came, big prevention is, in fact, we here at SP distribute them, and that's treated bed nets. They're very effective as long as the person is using them for their intended purpose, and as long as we get behavioral change to get people in hot African nights to climb under, a bed net and tuck it in around the edges of the bed so that they're protected from the bite of an infected mosquito. Those are very hard things to overcome. But we do distribute them. They do require an education and a training, and the fact is we want those bed nets used by the people who are the most susceptible, and we want them used for the children under 5, and we want them used for women in pregnancy. I've got here a couple of uses of bed nets that can happen for us, and we saw more than one of this in Sudan, up in the Qim area. This one here is where the bed net is being used as a mango tree protector to reduce fly contact with the mangoes, or to keep animals from coming in and using the net. And then the next one down here is we were interviewing this couple in Mozambique and had not looked over towards their dwelling. So we were sitting there talking to them, and we asked them if they had a bed net, and they said yes. And they pointed, and it's being used as a privacy screen over their, over the door opening into their dwelling area. And as you could look up above that, up in this area up here, you can see that it's largely open. And what the behavior of Anopheles mosquitoes is that they can detect a CO2 stream from a person, one of us, downstream of us, up to 2 miles away. And once they fly into that CO2 stream, they will turn and fly up the stream towards the source, 2 miles. And they will fly until they run into something like a dwelling, or like the grass dwelling here that we see in this picture. And they run into that, they hit it, and they stop. And what they do is they land, and then they walk upwards. They go up until they come to an opening, and they go over the top and then into the dwelling. And so, those of us who are familiar with structures in Africa, whether they be made from concrete, mud, or reeds, are all aware that at the top they have an opening between the roof, or this covering, and the wall itself, usually to let out, it's for ventilation and smoke if they happen to cook inside. But they're all open there, so the mosquitoes are not kept out by dwellings at all.
Now, what's the lifespan of a mosquito once he hits treated net?
If he hits it, like the ones that are on the market now, minutes. Yeah, they're going to die quickly. Yeah, if they come in contact with a treated bed net, they are going to die quickly, because what they do is pick it up on their body. Yeah. Whether or not they can get in to bite the person, because they can get through a bed net. If they sit there and fiddle with it for a while, they can get through it. Is highly problematic. The thing is, I was just reviewing just before this this talk, is they're looking at purchasing a new source of bed nets here at SP, which are using pyrethrins, as the treatment agency. These bed nets are now going to be effective in the field for up to 5 years, because they found a method of now combining the insecticide in droplets inside the fiber, so that even if they're washed, it keeps working itself to the surface.
So cost of a bed net?
Cost of a bed net about $5 for us. Yeah. So as far as people buying them themselves, no, but as far as us distributing to them for use, yes. For those of us who go to the field, we know that there are 3 effective, prophylaxis out there. There's more than 3, but these 3 are universally effective. And it's doxycycline, malarone, and mefloquine. There's, various objections to long-term use of these, prophylactic drugs, but other than the fact that with doxy you can become susceptible to the sunshine and get sunburn, or have sensitivity to sunlight, there's really no reason for a person giving for that we've been able to find for not taking malaria prophylaxis for the time that they are in the field now. Whether having a person who is born and grows up in these countries take prophylaxis is not something we would advocate. But then we need to protect them from the effects of malaria. But it's something for us that we need to keep in mind. There are no known. Go ahead, speak to it.
The only little caveat I want to give is because a lot of people will mention with Larium or methylquin, the generic name, there is a black box warning for persons with psychological diagnoses that it should be used with caution. But that gets, I think way overstated in terms of, persons without these diagnoses. I mean, they can use it very effectively, and you only have to take it once a week as opposed to daily, so there's probably improved compliance. So it's an excellent drug. It gets a bad rap for that, but.
And the reason I haven't approached treatment in any of these diseases is because the treatments are all readily available. The directions for the use of the treatments are all readily available. We teach it when we teach our community health workers about the dosage and the drugs themselves. But, you, as physicians, you all know that you have many references available for, what drug to use and where. Your references will also cover if you for treatment, for example, if it is a strain that is still chloroquine resistant, then the treatment is use chloroquine. If it's not chloroquine resistant, if it is chloroquine resistant, then you step that up, and it's a stepwise process all the way up to the currently most effective medication out there is artemisinin. But because of malaria's ability to develop resistance to drugs, we hold off the big gun until we have to use it, in the hopes of delaying it. There are now artemisinin-resistant strains of malaria in the sub-Asian continent, and places where we have people and places where people are exposed. That the resistance isn't all that prevalent yet in those areas, but it is there. Now, go back to the main theme that I wanted to talk to you about. This is a graph that puts together, this comes from the Child's Survival Initiative. And what it does is it puts together the data that shows you what the current trajectory of, reduction, and U5-CMR, treatment mortality rate is. It shows you what the green line, which is right down here, was what they were hoping to achieve with the Millennium Development Goals. And what you can see is considerably below the real line, which is represented inside the red circle at the top. And the Child Survival Initiative has instituted a new goal, which I think is also, unreasonable and going to be very difficult to achieve, and that's represented by the blue line. But as an epidemiologist, what I want to point out to you here is the fact that every one of those curves is leveling out. As they, I can't use a pointer other than the fact to show you that within the red circle, it shows that every one of those curves, both of the theoretical, the nice ones to have, and the others are leveling out. And if I drew a line in, I would draw the line in even above the top line there. Because what's happened is that in the world, and what we've been able to do is we've reached the children, largely reached the children that are reachable. We've gotten to the major villages and urban areas, and we're treating those people. And so what we've done is the low-hanging fruit is, if you want to use that term, I'm not one that likes cliches, but that one's pretty descriptive. The low-hanging fruit's been picked. We've saved the lives that we can save through those means. And what we're doing is we've entered an area now where we're getting to the more and more difficult, kids to reach, to get to save their lives. And
don't you think that's also due to the fact that those that you can reach are the more affluent?
yes, it
And
is.
the more educated and the more city-centered, and it's less costly to treat those people?
Dick, that's exactly right. Exactly what you said. You know, it's the kids who have access to care. You know, whether the care is available either through the government, like in Bolivia, where they provide it all for free if the child's under 5, or if it's a child in Africa where the parents have to go out and buy the medications or pay for the health services. It's the more it's the kids who have, and the kids who are located in areas where they have access. I want to, this is a lot of writing, and so what I've done is extracted out sentences out of this, and I'm going to walk you through where we're at today. And it says the poorest and most deprived children often have the highest risk of infection and severe disease, but are the least likely to receive treatment. Those are the kids that are in that part of the curve that's leveled out, and the children that are remaining to be touched. If we could extend the healthcare system into hard-to-reach and underserved communities, it says here it's essential. It is essential. If we can do it, that's the way to reach those kids, to reduce child deaths, and particularly those due to pneumonia or diarrhea. Malaria is the same way. Malaria is easy to diagnose with the rapid diagnostic test. It's easy to treat. And could be done by, that can be done by people with limited training. There's an accumulating body of evidence which proves that trained and supervised community health workers can provide high-quality care that substantially improves child health outcomes. The data is now, when I first started this 4 years ago, the data was there, but it was sparse, but it is now overwhelming. When God has an idea that it's time to move, and He gave me the idea for community-based primary health care and the Village Samaritan program when I came out of Africa, serving in Liberia to put a ceiling in a chapel, and He pointed out to me that there was a need there and how it could be met. When God has an idea, He offers us the opportunity. He's moving. He's about in the world. He's doing what He's going to do. He offers us as Christians a chance to jump on board and be part of what He's doing, but He's going to do it,
And the community health workers cheap.
Yes, very cheap. In fact, our community health workers through the Village Samaritan program are volunteers. Yeah. And
Not quite that cheap.
Yeah, they're volunteers. And besides being volunteers, they are community people from the communities that they stay and serve. That's the reason they stay as volunteers. And the cost of the Village Samaritan program is 13 cents per villager per year. I mean, it's dirt cheap, and we can save these lives.
What does that cost include, Tom?
The cost includes the medications and the training and the supervision, because we have a trained health person, usually a nurse or a physician that oversees several of and checks in on them on a regular basis and supervises their activity, make sure that they're sticking to their protocols and not just passing out antibiotics.
That does not include immunizations.
No, it does not, because we can't at the current time do immunizations, okay? Community health workers should deliver integrated treatment services for common childhood illnesses such as pneumonia, diarrhea, and malaria. And programmatic experiences shows that the integrated strategy can manage treatment coverage and improve the quality of care for sick children. As I go out and interview villagers and villages around the world, I have not found one village in the hundreds that I've been in that would object to having a village health program. I mean, they all are very enthusiastic about getting it. When you ask them about what they do currently for care, they're, we're looking for villages that are at least 3 hours by any means of transportation from any source of health care when we look to put our program out there. We want to get to the poorest of the poor, the remotest of the remote, to take this service. And so, but we're interviewing them about the children and what they die of, and how many children in their village or set of villages died, and what causes. And, and we say to them, it gets down to the point of, well, it takes me, 45 minutes to get to a bus that comes by only once a day at 5 in the morning. And, so if I've got a child that's sick, I've got to get that child up, get them to the bus by 5 in the morning because that's when the bus comes by. It's a 2.5-hour ride into, where there is a treatment available for these children. So now that we've talked 45 minutes plus 2.5 hours, we're 3 hours into getting the child in. Once they're in the city where the bus lets them out, it's another 45 minutes to an hour walk to the nearest clinic, which they now joined a line of several hundred kids or people that are waiting to be seen that day. They wait all day long and may or may not be seen, and at the end of the day, if they are seen, they're given a slip of paper because the health center just happens to not have the medication available. They're given a slip of paper and told you, this is the medication you need, you've got to go out and find it on the market. They go back home. One is they can't hardly afford the bus ride into town, and they certainly can't afford to go buy the medicine. So you ask them, okay, given all of that, who makes the decision? How do you make the decision to take the child to care? And they said, we don't. They just die. Now, those 3 words I've heard so many times in so many countries that it makes me cry. They just die. Children are cheap out there. They're replaceable, I've been told. And they're not that way to God. And as I read to you in Scripture, they're not that way to Jesus. And I really think we need to, be focusing in on doing something real about it. This is my conclusion, and that's counter to our progress in reducing mortality in under 5 children. It is increasingly apparent that those from the remote rural households are being left behind. They're among the poorest of the poor and the most overlooked children. In remote locations, they remain virtually untouched by our advances in medicine and health. They number in the millions, and they are the most vulnerable. For geographical and financial reasons, they simply do not have access to care. We must, therefore, take care of them. For 2,800,000 children that will die each year from these 3 treatable diseases that we have discussed, we can make a difference. And I say that we can do this, and we have a Christian and a moral imperative to do so. I've got another champion that's out there. His name's Henry Perry. He's from this area. He's now a professor at Johns Hopkins University. He's been in the field, community-based primary health care, longer than I have, a lot longer. These are his words. We can make a difference.
Okay. For every 2,800,000 that die, 10 times that many have some compromise in their quality of life.
Amen. 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 They do. So, the fact is that we can make a tremendous impact just by simply employing trained community health workers to stay in their villages and to treat those 3 simple diseases in those villages. And, I think we have to do so. Okay. Find a way to do it.